Hello, and welcome to this Clinical Care Options Oncology podcast. I'm your host, Jervis Constanzo. In today's episode, we are joined by Dr. Virginia Kaklamani from UT Health San Antonio in San Antonio, Texas, Dr. Erica Mayer from Dana-Farber Cancer Institute in Boston, Massachusetts, and Dr. Laura Spring from the Massachusetts General Hospital in Boston, Massachusetts. Together, they will be discussing clinical highlights, new emerging data, and practical takeaways from studies on oral SERDs in patients with HR-positive, HER2-negative, ESR-mutant advanced breast cancer that were presented at a satellite symposium held at the 2024 San Antonio Breast Cancer Symposium in San Antonio, Texas. This episode is part of a larger educational program entitled Estrogen Receptor Mutations in HR-Positive Advanced Breast Cancer, Next Generation Practice Recommendations on Mutation Screening to Guide Therapeutic Decisions. For more information on Drs. Kaklamani, Mayer, and Spring, along with a link to the complete program including downloadable slide sets and on-demand webcast, please visit the show notes for this episode. Now let's hear what the experts have to say on data presented for HR-positive, HER2-negative, ESR1-mutant advanced breast cancer.
Hello, everybody. We're going to focus on estrogen receptor mutations in HR-positive breast cancer and the next generation practice recommendations. So I'll start by talking about oral SERDs and how we integrate those in the treatment of patients with HR-positive disease. Erica is going to go into sequencing novel SERDs, and then finally Laura will go over adverse events, which is extremely important when we're treating our patients because this is how to treat them effectively. So here are the guidelines for when to do ESR1 mutation testing. We have the ASCO and NCCN guidelines in this part of the world. The routine testing, as far as ASCO is concerned, is in patients that have recurrence or progression on endocrine therapy plus minus a CDK4/6 inhibitor. So not in the first line setting, but in that second, third line setting. The testing by blood-based ctDNA, which is preferred, we'll discuss why this is the case. NCCN says something pretty similar. We assess ESR1 mutations at disease progression after previous lines of endocrine therapy. So why is this and why are we making such a big deal out of these ESR1 mutations? And the reason we make a big deal is because we have several oral SERDs, selective estrogen receptor degraders or downregulators, depending on who you talk to, that seem to be active in patients that have tumors with ESR1 mutations. When we talk about HR-positive metastatic breast cancer, it used to be very simple. We actually only had fulvestrant and aromatase inhibitors. Then we added CDK4/6 inhibitors, but we knew that we would give them mostly in the first-line setting. Now it's gotten very complicated. This is because we started genotyping our patients. And you may or may not recall when we started doing debates at SABCS, the first debate was, should we do NGS testing or not? And Fabrice André was the against person, and he won because the NGS testing was not indicated in breast cancer. And I think if you ask any breast cancer medical oncologist now, the answer is absolutely yes. So things have changed quite a bit in the past 8 years. And the reason is we have targeted agents such as PI3 kinase inhibitors and AKT inhibitors and oral SERDs that attack or that preferentially work in tumors that have ESR1 mutation. First-line therapy is going to be with a CDK4/6 inhibitor and endocrine therapy unless patients meet the criteria for INAVO, in which case you may want to consider inavolisib as well. Second-line therapy will depend on what the molecular characteristics of the tumor are. Does the tumor have an ESR1 mutation, a PIK3CA mutation, changes in the AKT pathway, germline BRCA mutations, and so forth? If the tumor has an ESR1 mutation, elacestrant is something to consider. If they have any mutation in the AKT pathway, we have capivasertib or alpelisib, and then germline BRCA mutations, we start talking about PARP inhibitors that have had good data in the metastatic setting. And obviously, what do we do in the wild-type patients? And so far, I think most of us would be discussing everolimus or potentially giving a second-line CDK4/6 inhibitor. And what do we do after that? We have to decide whether to move on to cytotoxic agents. And now we have capecitabine, but also we have trastuzumab deruxtecan in that first-line setting that might be used as well in these patients. So very crowded field. So let's talk a little bit about these ESR1 mutations. What are they? They're mutations that happen in the ligand binding domain of the estrogen receptor. And what that means is the place in the ER that estrogen binds. And they make the receptor constitutively active. That means that the receptor does not need estrogen to be activated. It's already activated, which is why aromatase inhibitors won't work, because aromatase inhibitors are going to take away estrogen that the receptor doesn't need. What happens in tumors, first of all, when do these ESR1 mutations develop? You're not going to see them in the primary tumor. So if you biopsy a primary tumor, the chance of you finding an ESR1 mutation is very close to 0%. They develop when tumors become endocrine resistant because they are exposed to anti-estrogens. So the longer the tumor is exposed to anti-estrogens, the better the chance that you will find an ESR1 mutation. So in ER-negative breast cancers, 0% of these cancers have ESR1 mutations. Non-metastatic, less than 1%. First line, you're going to find around 5%, but then in that second, third line, we go up to even 50% of ESR1 mutations. So these are subclonal mutations, and that's why it's important to also test them in the blood and not the tissue. In those first-line trials, Mona Lisa 2, we only 4%, but once we get to those second, third-line trials, that's where we get to up to 40% or so of incidence of ESR1 mutations. So Nick Turner and his group did a wonderful study looking at ctDNA in paired samples, tissue and liquid. And what he found was that if you only do tissue, you're probably you're missing around 20 to 25% of these mutations. Whereas if you do liquid, you will identify these mutations. And the reason is that because these are subclonal mutations, they're not going to be present in every tissue you test. They're going to be present potentially in one or two of these metastatic sites. But all these sites are going to shed their DNA into the blood that you're going to measure. And therefore, doing a liquid biopsy is going to find those ESR1 mutations. What do? They make tumors more aggressive, and the patients that have tumors with ESR1 mutations have worse outcomes. And we've seen this from multiple clinical trials. It also seems that that's where fulvestrant works better than aromatase inhibitors. So aromatase inhibitors, we know, are inferior to fulvestrant, but it seems that they're inferior to fulvestrant only in tumors that have ESR1 mutations. And we've seen this with Bolero-2 as well, where patients that have mutated tumors have worse outcomes compared to patients that have wild-type tumors. So this wonderful trial that was also presented at SABCS a few years ago, the PADA-1 trial, looked at this very intriguing design where we are not waiting for the disease to progress clinically to act on it, but we're actually looking at ESR1 mutations that develop over time. So we're looking at molecular progression instead of clinical progression. So these were patients that were all on palbociclib and an aromatase inhibitor. And then the liquid was tested for ESR1 mutations. And once we started seeing these ESR1 mutations increasing, so at molecular progression, assuming the patient's cancer was clinically either stable or responding, patients were either continued on the same therapy or endocrine therapy was switched. So continuing the CDK4/6 inhibitor, but now moving on to fulvestrant. And what the trial showed was that the patients that were switched to fulvestrant actually had better outcomes, which was extremely interesting. It also showed that by switching to fulvestrant, we were able to clear some of these ESR1 mutations. So we were able to reverse this molecular progression. And you can see that the patients, and also the patients that had clearance of these mutations, had an improved median progression-free survival compared to the patients that did not have clearance of their ESR1 mutations. And the difference was pretty interesting because the patients that had clearance, they had a median PFS of 24 months, but the patients that did not have clearance had a median PFS of 7.4 months. And then what they did was they crossed over. And so the patients that ended up having disease progression on imaging, they were then switched to fulvestrant. So to say, do we really need to switch them early on when there's molecular progression, or can we wait until there's clinical progression to switch them? And the answer was that we actually will benefit our patients if we switch them early at molecular progression and not at clinical progression. So a very provocative study. Obviously, a small study that is going to get replicated very soon. And then finally, they actually tracked the ESR1 mutations. And again, what they were able to find was that by switching patients from an AI to fulvestrant, they were decreasing the number of ESR1 mutations and also improving outcomes of the patients. Now, as far as what kind of ESR1 mutations patients had, it actually also made a difference. And so the patients that had monoclonal versus polyclonal mutations, there were a little bit of a difference in the results. And also patients with one of the most common ESR1 mutations, the Y537S, also had some differences in results. So all of these things end up actually playing a pretty big role when we assess ESR1 mutation status. They're not present in triple negative. They're not present in ER negative HER2 positives. They're only present in ER positive tumors. And something else that's interesting is the fact that if you've exposed the tumor to a CDK4/6 inhibitor, you have a higher likelihood of seeing these ESR1 mutations, something that we weren't really aware of previously. So important to know that the more we use CDK4/6 inhibitors, the more we're going to generate these ESR1 mutations. Laura, tell me what you usually do in clinic. You have a patient comes in, they have symptoms of metastatic disease, you do a scan and you find that there's a liver lesion and a bone lesion.
Yeah, so even, while I'm arranging a biopsy, I'm usually sending ctDNA that day when it's pretty high suspicion.
So you send liquid biopsy before you even do an actual tissue biopsy. Erica.
I think that's actually really important to say in the context of showing the INAVO120 study, because that study was for patients presenting with metastatic disease with a known PIK3CA mutation. So you need to know they have the mutation to give them the therapy. And the timing is such that, it takes a couple of weeks to get the ctDNA back. So if you suspect metastatic disease, I do the same thing. When I'm booking my biopsy where I'll get the tissue for the NGS, I'll send the ctDNA so I can at least start knowing if I should be thinking about the INAVO regimen for my patient.
And I sometimes get that liquid biopsy back, before we get our biopsy results back.
Yeah. This is important, and so much of this is logistics, right? You have the patient, they're sitting in front of you, you're talking about them potentially having metastatic disease, and then you have to schedule a biopsy, which I think even in the perfect scenario will take at least a week, if not two, to schedule. So you have 2 weeks. Then you get the results back, and it takes a couple days, again, in a perfect world, for them to see you in clinic, so you give them the results. And then you talk to them about doing next generation sequencing on that tissue, which will take another couple of weeks. So they come back, now we're 4 weeks out, and now they have a mutation, and you decide to give them therapy, which is an oral agent, which again, in the perfect world, will take a week and a half or so to get the results back. So now we're past a month and a half for patients that have primary or secondary endocrine resistance and obviously have aggressive tumors. So I think your approach, and I didn't do that up until the INAVO approval, but now this is something that I will do as well. And again, assuming that everything is perfect and we can send multiple tests out. But let's say now we're in that first line therapy, we have disease progression. How would ESR1 mutation status change your management, Erica?
Well, I think, thinking about that flow chart that we just went through, and we'll do it again in a little bit, knowing which kind of bucket you should be thinking about for your therapies, you need to know the tumor genomic profiling at that time. And as we've talked about, particularly with ESR1, it's a kinetic mutation. So the longer a patient's been on endocrine therapy, the greater the likelihood that the cancer will develop the mutation. So I need to know that when I'm picking my second line therapy. Again, getting back to logistics, if I'm seeing a patient in clinic and I'm beginning to suspect that cancer's beginning to progress, maybe more symptoms, the labs, the tumor markers, I'll send it, a little early while I'm getting them set up for their scan, because I really want that information in hand. So when I'm counseling about our next steps in treatment, I'll know exactly what I'm dealing with and I'll be able to recommend the right therapy. And I think some of the questions that we've been thinking about have to do with sequencing. And, is there a way that we could move from SERD to SERD the way we do with our traditional endocrine therapy? Or do we understand mechanisms of resistance with oral SERDs? Virginia, what do we know about this?
This is tough because we don't know a lot. And, we know obviously that emergence of ESR1 mutations causes resistance to aromatase inhibitors, fulvestrant. The reason I didn't mention that why oral SERDs is because we can up the dose. And with fulvestrant and IM injection, we have limitations as to how many buttocks we can inject. But with oral SERDs, we can just increase the dose and we overwhelm the estrogen receptor, and that's why they're beneficial. But once there's resistance to these oral SERDs, it's really hard what to do, and we don't really have any data sequencing the oral SERDs. So I think this is something that we need to develop, and it'll be really interesting to see those results.
Yeah, totally agree. And, another question, and this sort of gets to the EMBER-3 data, monotherapy versus combination therapy. Laura, what's your take?
Yeah, I think that's a key, is thinking about like, who are you comfortable with giving monotherapy to? So I think it's hard. All the algorithms we have now, they don't really speak about, they can't in one page kind of speak about all the patient factors we think about, like sites of disease, pace of progression, and who you might feel fine with a single agent oral SERD, versus when we think about the doublet. I think on one hand you have a doublet, which is appealing. Another hand, it wasn't specific or required ESR1. The benefit was seen regardless, so that's an appeal. And we do have that group of patients who don't have ESR1 and don't have PIK3CA, and that's a bucket that could fit nicely in.
Great. And one more question before we switch over. We sort of have alluded to it a little bit in some of the cases. What do you think about the co-mutations? How is best to manage the co-mutation patients? Again, they're unusual, but now that we have this growing wealth of targeted agents, how do we pick which is the best one for our patient who might have both?
I think that's where potentially combinations are going to be useful, maybe not. In the meantime, I personally look at the balance of efficacy and toxicity. And you mentioned the fact that at least with the data that we have with elacestrant, even though there is a clinical benefit of around 5.5 months in a subset of a subset, it's still a little less than what you're seeing with all of the other subsets of patients, including P53 mutations, which I thought would have done worse. So we have to be a little careful, but it's so much easier to give elacestrant than to give alpelisib or capivasertib to our patients. So I have to have a balanced discussion, but we have clinical trials and that's what I recommend. But if we don't have a clinical trial, I typically lean toward giving elacestrant and then keeping my AKT inhibitor, PIK3CA, to progression.
Yeah, I think that's a great way to approach it.
I just want to do a more broader overview of thinking about some of the different classes of adverse events that we see with these agents. And importantly, they're not all seen with all of them. So some of the most common ones that we are seeing kind of across the class are the gastrointestinal adverse events. So nausea, vomiting, diarrhea, also seeing some neutropenia, some fatigue, and then some of the kind of typical endocrine therapy side effects such as hot flashes and arthralgias. The less common ones are actually the ones that we're not seeing with all the agents. So bradycardia and visual disturbances have been both AEs of interest that, again, we're not seeing with all the drugs, and we'll review that. So first, to talk a bit about the bradycardia, the phase 1 study of giredestrant as monotherapy or in combination with palbociclib, and taking a deeper look at the bradycardia, these events turned out to be of low intensity. They were clinically manageable and reversible, and a dose-dependent impact as well. And then they did see higher rates in combination with palbociclib, and 30 milligrams was the dose of focus. So looking a little deeper into this, they looked at exercise stress tests and Holter monitor data as well. And overall in this small sub-study, looking at this dose of 100 milligrams, there was no clinically significant changes in heart rate, blood pressure, or exercise with the treatment. But besides that, so elacestrant, this is the approved agent. And in terms of the most common AEs that we see, of course, nausea, some vomiting, fatigue, some changes in the labs, including elevation of triglycerides, some arthralgias can be seen, some lab changes as well. Camizestrant, so that is one that visual disturbances can be seen. So at sort of the focused dose of 75 milligrams, typically the median onset was around 15 days or so. And this wasn't typically something patients were experiencing all day. It was on average usually once a day, and it was fairly short-lived and more peripheral and often described as occurring when there was a light change. So if you went, if you were outside in bright lights and then went into the dark, it would be more apt to happen then. And also with this agent, sinus bradycardia was observed and some of the GI side effects as well. With giredestrant, sinus bradycardia was observed again, as well as GI side effects, arthralgias, fatigue. We heard a bit from Dr. Mayer earlier about the AEs of imlunestrant, since we just saw the EMBER-3 results. And again, we did not see bradycardia or the visual disturbances, but did see some of those GI side effects and fatigue. And so let's dive a bit more into EMERALD, since this represents one, the approved agent so far. So if you look comparing the standard of care on the right to elacestrant on the left, first, I think we have to remember that our standard of care endocrine therapies do have a fair amount of adverse events themselves. So I think it's really important to do a close comparison. And when you do that, I think what really sticks out, of course, is that you're seeing certainly more nausea, but the fatigue was really quite similar. As you look down the list, it's really the GI side effects that stick out more as, being higher in the elacestrant group. So overall, nausea-related AEs leading to dose reduction or dose discontinuation occurred in only 1.3% of patients in the elacestrant arm, and not surprisingly, 0 in the standard of care arm. And then in terms of nausea-related AEs leading to antiemetic use, that occurred in 8% of the patients receiving elacestrant versus about 10.3% actually of those receiving AI and 3.7% of those receiving fulvestrant. In terms of SERENA-2, looking at camizestrant, we've spoken a bit about this agent already, but here's helpful as we're looking at the different doses. So 75 versus 150 versus 300. And as you heard, 75 is what's being explored. And in terms of the visual disturbances and the sinus bradycardia, as you kind of move to the right again, you see a clearly dose-dependent effect there. Otherwise, again, there's some of the GI side effects, some of the lab abnormalities were seen as well, and the majority of them were dose-dependent. So in terms of, just thinking about kind of hot flashes in general with the oral SERDs, I think overall really not seeing as much of that compared to kind of our standard endocrine therapies. Of course, we have a variety of options to treat them. And I think that these are kind of the same approaches that can be taken with oral SERDs, of course. So looking at some of these options here, so, hormone replacement therapy would not be something we would do. We sometimes selectively will use vaginal estrogen, but that's not so much to treat hot flashes. We do now have approval of an NK3 receptor agonist agent, but importantly to note in discussion with patients is that in the trial that led to the FDA approval of that agent, breast cancer patients were not included in that study. And of course, there's a number of off-label uses with different SSRIs, SNRIs, gabapentin, oxybutynin, clonidine, all different options we can try with our patients. So in terms of thinking about dose modifications for elacestrant, so here's, just thinking about each generally AEs by grade and how to approach it. So for grade 1, we're typically continuing treatment without dose adjustment. For grade 2, typically we'll interrupt treatment until it improves to grade 1 or less and then resume at the same dose. While for grade 3 is typically when we're holding, and then when it improves, we will reduce the dose. Same thing with grade 4, but if that recurs again, that's when we typically will permanently stop. So 345 milligrams going down to 258 and then to 172. And once you do make a dose reduction, you are switching your tablet from 345 to 86. So then at the first dose reduction, the patient would be taking 3 of those tablets. So in terms of some other supportive care strategies to think about with elacestrant, so as we mentioned, there could be some impacts on the triglycerides and also on cholesterol as well. But again, the incidence of grade 3 and 4 events were quite low, but it is recommended that patients should receive occasional lipid profile monitoring prior to starting therapy and while on it. Then in terms of the nausea and vomiting, which, we are kind of seeing overall a bit with this class of medications, some strategies that help are taking the agent with food, swallowing the tablet whole, trying to take that generally the same time of day. Then, of course, if a dose is missed more than 6 hours, or if a patient were to vomit, they should be counseled not to double up and just to take it the next day. We're not typically starting off with prophylactic anti-nausea, but typically making it available as needed. But that can, taking it in advance of taking the medication is a strategy that can be used if nausea is an issue. So in terms of some questions for our panel, so I know you both have a lot of experience with some of the different trials, and of course now we have elacestrant approved as well. So when you're, maybe we can start with elacestrant. When you're starting a patient on it, what specific AEs do you tend to focus on in your conversations with them?
So I'll talk about GI toxicity, and even though, it's interesting on the Emerald trial, fewer patients on elacestrant took antiemetics than an AI. And if you talk to patients about AIs, I don't think any of us talk about nausea and taking anti-nausea medications. Now, we participated in Emerald, and when I asked my coordinator, so patients taking antiemetics, was that new patients or was that patients that were taking antiemetics potentially previously and then discontinued? And she said they could have been taking them previously and then discontinued, so who knows. But that's typically what I will focus on.
Mm-hmm. Everything the same.
Yeah, I mean, I prepare them for the risk of GI side effects, but I'll say anecdotally, it's a really well-tolerated medication.
Yeah.
Haven't really had too much trouble. But I do think it's important to check the lipid panel and keep that in mind when patients are onboarding onto the drug.
And I think in part that's why there's so much excitement about their use in the early breast cancer setting, because patients really do want an alternative, as the endocrine therapies we have can be so challenging for many patients. So in terms of SERD-related AEs, I think we've talked about the GI AEs a bit and some strategies there, but in thinking about some of the different clinical trials you've been involved with, any particular anecdotes or anything you want to share in terms of handling some of those AEs?
I think that, particularly the oral SERDs that have the visual side effects and the bradycardia are ones that we just have to keep an eye on. Thankfully, those are both very mild side effects. The photopsia is absolutely not related to any visual acuity change. It's very minor. The patients who experience it don't complain. I mean, you ask them and they'll say it, but it's not something that affects their daily life. The bradycardia is totally asymptomatic. And as we saw from Tom Nealon's study, if a patient is bradycardic and they exercise, they can increase their heart rate appropriately. So we know there's no negative effect on the heart. I think the biggest downside is that in medical oncology practices, we don't like abnormal vital signs. And, if your patient comes in bradycardic, the clinic staff will go crazy and, come and find you. And so if that becomes something more common in our clinics, we're going to have to kind of educate our group about how not to, get too worried if the patient's heart rate is 45, but they are asymptomatic, because that's something that happens with the drug. But I think aside from that, I've been really impressed with the side effect profile of this class of medications.
So speaking of side effects, as far as osteoporosis and cardiovascular side effects, how do you consider those as related to AIs? Because we're going to be comparing these agents, especially if they move into the adjuvant settings, to aromatase inhibitors.
I think the osteoporosis and cardiovascular effects that we associate with aromatase inhibitors developed out of the large adjuvant trials with long-term follow-up, because those are real long-term chronic toxicities. So I don't think we actually know that data for the SERDs, because we don't have published data or presented data from long-term exposure. So I don't think that we know the answer to that, but I also don't think there's a signal right now that there's going to be some kind of different or new side effect that would be worse than anything we've seen with aromatase inhibitor.
Yeah, I would hope it may be better than the AI. Yeah. Just thinking about mechanism of action.
Another interesting question. Would you be more likely to use a SERD plus a CDK4/6 inhibitor in patients that have a dual mutation of ESR1 and PIK3CA?
Yeah, I mean, there's back to this question of the dual mutation and how to address that. And, I think, again, it's a rare patient in our practices, but, picking up on what we talked about before, I think that we want to be looking at all of the clinical pathologic features. We know that both of those mutations, ESR1 and PIK3CA, can be associated with more resistant disease or more aggressive disease, but not every time. And if a patient meets that kind of space where elacestrant has performed very well with a long prior duration of disease control on aromatase inhibitor and CDK4/6 inhibitor, that's not really behaving like a cancer that's driven by the PIK3CA mutation. And maybe that cancer and the resistance in the cancer is driven more by the newly acquired ESR1 mutation, in which case using the oral SERD would be more appropriate. On the other hand, if the patient progressed relatively quickly on their prior aromatase inhibitor and CDK4/6 inhibitor, and they have a known PIK3CA mutation, that cancer may be driven more by the PIK3CA pathway, and targeting that may be better. Using combinations would be great, because then you could get to both at the same time. We also don't know about sequencing, and maybe if you do one and then the other, there might not be a big difference. So there's a lot more work to be done in that space.
Yeah. So you presented the curves on Emerald, and what is interesting is that for both groups, there is a drop. And for the standard of care group, there's a bigger drop within the first scan, so within 2 months. What are we doing for these patients that are having progression within 2 months of endocrine therapy?
I distinctly remember when you presented this data, and Fabrice André, I think, was your discussant, and he pointed out that big drop. And I think that those are patients for whom endocrine therapy may not be the right choice. They may need something different, like TDXD or, another sort of chemotherapy type option. But our challenge is we don't know that necessarily when we start the treatment. And what can we learn or study or, get out of the patient or their cancer that will help us know that, which direction to go and prevent that steep drop? No, what do you think?
Yeah, no, I agree. I think there's patients who, you see they have very slow progression. You're pretty confident they're not going to be in that steep drop off. Others where the progression, as you said, was maybe more rapid, very short time on prior CDK4/6. And I do think when you repeat the liquid biopsy, you sometimes can get a hint too when you see the TP53 mutations popping up or just, a whole lot of new alterations. You're just kind of more concerned that this disease is evolving, becoming more aggressive. So that's where I'm just less comfortable with single agent oral SERD. But at the same time, I think we just like in a trial, right, as you said, it was basically the progression occurred by the first scans. You're, keeping a very close eye on those patients.
Now, we presented the data from PADA-1 and SERENA-6 is hopefully going to be presented soon as well. But in the meantime, you have a patient that is on endocrine therapy and you're monitoring them. What signals do you get that tell you that, hey, maybe I should actually genomically test these patients to see if they're having a molecular progression?
Yes, I think a bit, Erica spoke about this earlier, maybe there's some signs, right? Scans are stable, but the tumor markers keep going up, or maybe there's some symptoms you can't quite explain. That's where I sometimes do get the liquid biopsy a bit earlier to try to maybe not be a tiebreaker, but just help me kind of get a sense of what's going on.
I think, as we look at the model of PADA-1 or SERENA-6, which is, very elegant to look at this real-time monitoring. At the same time, I'm not sure we could operationalize that within our healthcare system because it would be very expensive. And particularly for patients who have very long durations of disease control on their first-line therapy, it doesn't really make sense to be doing all that serial testing. So I think finding the sweet spot where you get enough hints that it's time to check. And maybe you're wrong, maybe nothing's happening and it was a false alarm. But, having the ability to check, but not checking too much.
And I feel we see this all the time, this, called mixed response, where yes, there's a couple of lesions that are shrinking, but a couple that are kind of pushing the boundary of progression. And of course, our radiologists will say, pretty much stable disease, but maybe that's when we're realizing that some of these lesions may be developing the ESR1 mutations, which is why they're growing. And maybe then potentially do that testing, because you're right, we can't do it every month. So I mentioned that it seems that these ESR1 mutations are happening more if there's a CDK4/6 inhibitor used, but now we're using CDK4/6 inhibitors in the adjuvant setting. So how do you guys think it's going to evolve? Are we going to see more of these mutations in that first line?
Be interesting. I think we need to see the data. I think, we're still, it seems very early, even in the adjuvant CDK4/6 space. I think probably no is my guess. I think it really is still response to, being on endocrine therapy in the metastatic setting. But I think that'll be a really interesting question to look into.
Development of ESR1 mutation is a mechanism of endocrine resistance, not CDK4/6 inhibitor resistance. So the use of the CDK4/6 inhibitor itself, I don't think is going to contribute. But I do think we give much longer durations of endocrine therapy than we ever did before. And that's what's going to drive a greater enrichment of ESR1 mutations at time of disease recurrence.
And I think you answered the next question of why do we see these mutations? And it's really probably the fact that we are exposing patients to more endocrine therapy. Remember, the median PFS is doubling with the use of a CDK4/6 inhibitor. So maybe that's why, because as far as I know, the mechanisms of CDK4/6 resistance have nothing to do with ESR1 mutations.
Right.
And another quick question, we use SERDs, but we always use them with LHRH agonists. Do we have to?
I think it's not mandated in the adjuvant trials.
Yeah.
Mechanistically, it seems like we wouldn't have to.
We wouldn't have to. I know there was some data initially,
safer.
And so that's why everybody started using fulvestrant. And I've talked to the company saying, can we relook at this? Because is there a reason why we should be using SERDs and LHRH agonists which have their own toxicity profile? But
I would say in the adjuvant setting, any premenopausal patient who would be eligible for an adjuvant SERD trial, which is designed to collect a higher risk patient, probably should be getting ovarian suppression anyway based on soft and text.
Yeah.
So it would be a very unusual premenopausal patient to go on. And actually, I don't think tamoxifen is a comparator arm in the studies also. So I think it's not exactly an active question because I think most people will be on it anyway.
I think on Elegant, we're allowing patients to go on tamoxifen. It's mostly switch. And then the last question, the results from EMBER-3. How do we sequence treatment in patients that now have PIK3CA mutations after progression on a CDK4/6 inhibitor? So have a CDK4/6 inhibitor patient has progression, also has a PIK3CA mutation. Assuming that imlunestrant and abemaciclib is approved, what are you guys doing clinically?
So we're saying no ESR.
No ESR1, but PIK3CA.
No ESR1.
Yeah. I think that if we're going to do genomically driven care, then I would probably want to target the PIK3CA mutation first versus not addressing it.
Yeah, I think the sweet spot for the imlunestrant abema will be that no ESR1, no PIK3CA group.
Yeah.
But I would
lay some of the everolimus
yes.
treatment.
But I think I would love to have the oral SERD and mutant-specific PI3 kinase inhibitor combination. That would be our dream therapy.
Perfect.
Thank you, Drs. Kaklamani, Mayer, and Spring, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Estrogen Receptor Mutations in HR-positive Advanced Breast Cancer, Next Generation Practice Recommendations on Mutation Screening to Guide Therapeutic Decisions, and to download a slide set associated with this discussion, please click the link in the show notes. As always, thanks for listening.